We have one more brief presentation, folks, that we're ready to prepare for you here, getting it all prepared to beam in, and then we're going to be moving to our panel discussion segments shortly thereafter. We wanted to get some pharmacist perspectives in the mix, of course, here today, and one I'm delighted to introduce is Dr. Ucheoma Nwizu, board-certified ambulatory care clinical pharmacist who currently practices as a lead clinical pharmacist at Neighborhood Health Center, the practice site at the Milwaukie Clinic. Her interests include chronic disease state management, particularly diabetes and hypertension. She is passionate about education and facilitating learning among clinicians who are either in practice or in training in both local and international settings. Uche also has the distinction of having survived CareOregon's pharmacy residency program, so she'll never have to demonstrate her bravery to us in any other way ever again. So let's lend our attention to Dr. Uche Nwizu.
Thank you, Paul, for that wonderful introduction. And today I've been tasked with discussing with you all on equity or even inequity in medication use. I'm going to be sharing with you based on my experience and a few things that I found based on research about the experiences of our patients with medication use. I did find a study that indicated that limited English proficient patients or LEP patients report more misunderstanding and negative drug reactions when taking prescribed medications compared to the English speaking patients. One of my colleagues did ask me, but why is this happening? And the answer is that we don't know, and we don't know mostly because we haven't investigated. And a lot of the studies and a lot of the data around limited English proficiency, it is not asking questions about why some of these negative impacts are noticed. And a lot of the studies also have not been translated into changes in healthcare policies. So there's not a lot of encouragement, I think, in studying this particular group of patients. I don't think we'll come up with a lot of answers, but I'm hoping that in our discussions that we'll come up with some solutions, at least some things to mitigate this problem at this time. When I was thinking about this presentation, I was thinking in terms of the medication use process. First it's prescribed, then it's dispensed, then the patient takes it. However, in my research, I found that a lot of things that affect the inequity in medication use stem from even the health policies. So I'll be focusing on health policies that affect medication use, and then prescribing, and then dispensing, and then the administration. Looking at health policies, a lot of the health policies have been structured around protecting the rights of linguistically diverse patients. We have a lot of policies around interpreter use. However, these policies have not translated to what it costs to use interpreters. And most clinics will have interpreter services available, but the providers still have the same time to use the interpreter. So patients who require an interpreter will have the same 20 minutes or 15 minutes or 30 minutes slot, depending on what the clinic's policy is, and not added time because they're using an interpreter. And there's also some fragmentation I see in patient information. A lot of the labels and leaflets that are around medications are in the industry generated. They have minimal government regulation. And so we find pharmacists and providers serving as intermediary between drug companies and patients, with no guidance as to what is, how to communicate these information. And like I said earlier, research findings have not translated to a lot of policy changes at this time. So a lot of the prescription labeling is still governed by the FDA and most state boards of pharmacy. And a lot of the regulation is around content, not format. And when you are limited in literacy, the content and the format is very important to determine how you understand the information. A lot of the pharmacies provide medication information, but this is voluntary. are not standardized. And so we know that we should write things in sixth grade education level. However, it's not also standardized, and nobody really goes to check whether these things are at sixth grade level. And when patients have limited English proficiency, I don't even think the sixth grade level cuts it at that time. In talking about the other processes and medication use, the prescribing, the dispensing, and in the administration, I will be talking on what has worked, what has not worked, and then maybe possible solutions for each of these steps. So in prescribing, we do know that there's an increased awareness about health inequity. Most providers are aware of this. We do know that there's language assistance and interpreter services available at most clinics. We also do know that there's access to written information in native languages. However, not all native languages are covered. I did have a patient on one occasion where I spoke Punjabi, and the interpreter that I got was actually residing in London. And I found that very interesting. We do have language concordant clinicians. So most clinics where you have strong presence of any particular minority group, you will hire clinicians that speak that language, like Spanish-speaking patients or Korean-speaking patients or Somali-speaking patients. And this has so far worked and has improved the equity in medication use. However, what has not worked, most clinics, or some clinics, not most clinics, are still not utilizing the interpreter services the way it was designed. Some interpreter services are hard to find. I do find that some of the services that we have are substandard. The interpreters add their own variety to what they are interpreting and not interpreting accurately like they are taught to. There is also the problem of even the patients who have information in their native language are also not able to read in that native language. So that's a problem. A lot of, or not a lot, some providers still believe that language barrier is a unidirectional challenge, meaning this patient is not understanding what I am saying. I noticed that they are not seeing it as I am not understanding what these patients are saying. And so the onus of change or the onus of or change is on the patient, not the provider. And I think that attitude impacts the way we provide care. The other thing that hasn't worked is the multifaceted process for prescription fill. So when you send the prescription over to the pharmacy, it's no longer in the hands of the provider at that time. It's now what the pharmacy does. And so what happens when prescriptions are discontinued? What happens when doses are changed? We find often that patients still take medications that have been discontinued because they are automated for refills, or we find that when doses are changed, patients are still taking the old doses because of these fills are still automated. I did run into some studies that looked into the misinterpretation of prescription instructions. And one of them found 79% of patients actually misinterpreted one or more of the 10 common prescription label instructions. Other studies showed anywhere between 30 and 50%. And I found that, and this is among patients who were not classified as limited English proficient patients. I found it quite interesting that this is a disease that we have. I wonder what it is for patients with limited English proficiency. So what are the possible solutions that we have? One of the things I would recommend is more time allotted to clinic visits. And I think that this is driven by the incentives to clinics to vary this visit time. I know that some clinics do have extended visit time for patients who they think have assessed as being complicated, but they don't they don't factor in this for the patients who have English, limited English proficiency. And so when you consider that any sentence you make is being translated to there's one more step of translation before the patient gets it, it can be challenging and it can be time consuming. I had a patient who, even though was Spanish, spoke Mistake. And so the interpreter that we had would speak Spanish to the son, who would now interpret the Spanish to Mistake to the patient. And that is like 3 times the amount of communication that we normally would do for when there's no language barrier. And so these visits take a long time, and providers are still limited to the 20 minutes to get things done. And when there's that time constraint, chances are that things are not going to be done thoroughly. The other possible solution that I'm thinking about is, can we have after visit summaries in audio? We have this extensive after visit summary that we give patients that explains what they should be doing. Is it possible to have an audio recording of what the interpreter has said? I'm sure if we put our minds to it, that can be made available to our patients. Can we use visual aids for medication education? Sometimes when we say take 2 tablets 3 times a day, some patients can't even read that. So are there possible ways of indicating that? For some of my patients, what I do is use markers on their prescription bottles to say 2, 2, 2, and they can understand that better than take 2 tablets 3 times a day. Other possible solutions will be ensuring that at every clinic visit, there's medication reconciliation, and making sure that this process is an interactive communication. It's quite interesting what you find out when you start looking at what a patient is actually taking. And if we can get the culture of having patients come to these clinic visits with their prescription bottles, that would help a lot. When doing medication reconciliation, of course, it's important to use multiple sources, patient's verbal report, patients demonstrating how they're taking the medication, and also the pharmacy record. One thing that has changed our practice or have improved my practice a lot is having the field history now visible on Epic. That way I don't have to call the pharmacist to find out if the patient has picked up the medications. It's visible on Epic if they have picked up this medication. That has cut down a lot of stress in my time, because this information are seen in real time and can help inform or guide the discussions that we have with the patients while they are in the clinic. Moving on to dispensing, I read the story about a patient in California, or a pharmacy in California, that had 2 different patients with same Vietnamese name. They both dropped off their prescription. One was for amoxicillin, the other one was for Premarin, and both were for women. And when the pharmacist handed the prescriptions out, he noticed that they had the same names, and he asked each patient to identify prescribing doctor, medication, and try to make sure everything was correct. And then only for an hour later, a 13-year-old boy walks up to his pharmacy and told the pharmacist, "This isn't my mom's medicine." And when the pharmacist asked the boy why his mom said yes earlier, the boy said his mom was afraid because she couldn't speak English. And even though the story is out of a pharmacy in California, it's a typical story that happens. And I see that a lot amongst my patients who are afraid to communicate to their pharmacists about their needs. So with dispensing, what is going well? Yes, we do have language assistance and interpreter services available. Yes, we do have access to written information in patients' native languages. Yes, we do have, in some pharmacies, language concordant pharmacy staff. Yes, I'm so happy that we have visible field history records, and we're now doing a lot of medication reconciliation in the clinics. So this has helped, but what is not going so well? There's still difficulty having telephone access to the pharmacy. When you call the pharmacy, I don't remember any of the pharmacies having, greetings in other languages. Sometimes the hold is forever, maybe through to no fault of the pharmacist. But I recently have had quite a number of experiences in pharmacies where I speak to a pharmacy staff and they tell me, they said to me, I can't understand a word you just said. In fact, it happened to me right before this call, and I introduce myself, I tell them what I want, and the next words are, I can't understand a word you just said. And that for me fills me with a lot of fury because I feel that as a healthcare professional, if I'm spoken to in this manner, I wonder how patients are spoken to. And so what this translates to is difficulties in filling prescriptions, when patients have to lose their prescriptions, getting things like lost prescription overrides, vacation overrides, pre-authorizations, those things that require patients to advocate for themselves. Those are not, patients usually would not get their prescriptions at that stage. Often I have had patients travel back to Mexico without their 3-month supply because they can't navigate that conversation with the pharmacist. Often when a patient is requiring pre-authorization, we'll have to step in from the clinic to get that done because they can't navigate that. When patients lose their prescriptions, they can't self-advocate. So we find clinics are doing that more and more now. And that is what I think is not going too well. Possible solutions. I used to work in retail pharmacy, so I do know that there's training in cultural competence and sensitivity, but I don't know whether who is trained and who is not trained. And it would be nice to reinforce. And sometimes the trainings in cultural sensitivity, it's just making people aware that there are people of other cultural backgrounds, but it doesn't make them aware on how to speak. For instance, I've heard it, if I can count more than 5 times while practicing in Oregon, I can't understand the word you just said. If pharmacy staff is still speaking like that, then there's a lot of training that still needs to be done. And then the other thing is the use of visual aids for prescription labeling. A lot of the labeling is still, the content is regulated, but the format is not. And so when you look at all the words that is on a prescription bottle, nothing matters to the patient except for how do I take those? And that is not visible to them, or it's not written in a way that they can understand. So when the patient picks up the medication, they go home and then we still notice some poor adherence. So what is working? We do know that some prescription directions are now being given in native languages. Thankfully, CareOregon still does 90-day fills and MedSync, which has been very helpful. However, what is not working is we still are seeing insufficient counseling. What are these medications used for? I feel that when a pharmacist counsels a patient, then it's easy to know what information they really need and how to put some supplemental information on the bottle so that they can take the medications appropriately. Things that are missed in counseling is things like duration of therapy, things like, for a statin, you're going to take it for the rest of your life, or for aspirin, you're going to take it for a certain period or for the rest of your life. And so when patients feel better, they stop because nobody told them that this is going to be ongoing. And also making sure that in counseling that the understanding is confirmed. The other thing that is not working is sometimes the vague directions on medications. For instance, if you say take it every 8 hours, what does that mean to a patient? But if you say take it at 6, take it at 2, take it at 10, then they are more likely to have concrete instructions about what to do. So what are the possible solutions? Again, medication reconciliations by providers and pharmacists, knowing that, asking the patient what they're taking, how they're taking it, providing medication counseling, things like medication organization, pill boxes, and visual aids will be helpful for patients, because sometimes I had a patient that had both ibuprofen and metformin prescription when he ran out of the metformin, he started taking the ibuprofen because they looked alike. And so if you had a medication organization and pill boxes, that would be avoided. All right, so these are the things that I've seen in my observation, in my little research and reading. I'd like to know what you think and what you see in your space. Feel free to share. And I think based on these, we can come up with a great plan on how to help patients with limited English proficiency. And thank you.
Thank you, Uche. It is wonderful to be able to have you join us for this presentation here today. Thank you so much for sharing your perspective and being so personal about your experiences. I think that is absolutely precisely what we need right now. Friends, that wraps up the first segment of our first half of our segments here this morning, where we conclude all of our didactic prepared presentations